Dr. Rastogi is back on.
Good job. You get a break. Well done.
I do.
Well
Thank
done.
you, guys.
I'm here with Dr. Nashi,
Take this
and we got Travis from Boston Scientific. So I'll have his hand right here. And we're all set. So very exciting. I'll let you go ahead and start with your slides here.
Thanks for having me. This has been I'm Sarah Nashi. I'm an interventional pain specialist in Cincinnati, and I'm going to talk today about Boston Scientific's Alpha WaveWriter System. I wanted to start out with a patient that I have. She's a 45-year-old female patient. Her name is Molly. She came to me about 5 years ago for management of spasticity with the diagnosis of MS. Shortly thereafter, she was doing some exercise at the gym, and she herniated a disc and ended up having an L5-S1 disc extrusion. We tried some conservative therapies. Ultimately, she had an L5-S1 fusion. That took her pain away for a year or two, and then she came back to me really with no surgical options. And at this point, I introduced her to the Boston SCS Alpha WaveWriter System. And I'm sharing this story with you because she has MS. She will need serial MRIs throughout the future. And now that we have full MRI conditionality, this is really impactful for patients that once couldn't have this therapy, now can have this therapy. And so going over some of the systems, Alpha WaveWriter has 4 IPGs. We have a 16 contact lead that we'll show you today, 32 contacts. There's rechargeable and non-rechargeable options. And what's nice about the non-rechargeable now is that all of the programs can be utilized. Before, you were limited to what programs are you could use, and now that's no longer the case. So that's really good.
Absolutely.
There's also Bluetooth capability where now when they change the programming, you can just hook it up to the Bluetooth. So you don't necessarily have to change the battery. You can just do the Bluetooth programming.
And your point about MRI compatibility has been a long time, pain point. We've had lots of MS patients who want to utilize this, but they knew they were going to get serial MRIs for the rest of their life, and they kind of held off because of that. And now they don't have to. So that's absolutely a great case.
Yeah. And so, some of the other indications, let me go, for spinal cord stimulation are complex regional pain syndrome. So we have a lot of patients that suffer with pain in one extremity or the other. Epidural fibrosis, the failed back surgical syndrome, axial low back pain is another good one. And then neuropathic pain. A lot of my
100%.
Patients with diabetic peripheral neuropathy are seeing great results with this system.
Yeah.
So today I'm also going to talk particularly about FAST. FAST stands for Fast Acting Subperception Therapy. To achieve FAST, you have to have precise targeting and proper neural dosing. And with that, you get FAST. And the cool thing about FAST is it has really made our trials a lot more effective. And then also, it's another program that stimulates the dorsal columns that you can run with Contour. So it in the trial phase, there used to be that it would take about 48 to 72 hours for patients to notice the benefits of the trial. Now, patients in about 2 minutes, you turn it on in the recovery area, and they're walking without their walkers. They can really get an effective trial, and then it's also very beneficial in the long run. And we'll look at some of the science-based data to show that it is sustainable here in a few minutes.
And I bet that's changed how many of your patients converted from trial to perm.
Yes.
They've improved that ratio.
Yes, because it's just profound. It's really
They get to notice it right then and there.
Yep, and it's a lot more evident to them that the therapy is helping. So we know that the SCS works, but now we have the science to back it. And at NANS, there were some newer outcomes that came out. Dr. Antonescu looked at reduction in pain, and not only reduction in pain scales that went down by 6.1, but also the ODI, so the functionality went down by 31 points at 3 months. So that's an improvement, a large improvement in function. And then we also Bayer looked at long-term, so sustainability of the therapy of FAST, and we can see that it is sustainable up to 2 years. The studies went out, and not only that, but the VAST score went down even a little bit more at 2 years than the 1 year mark, which I thought was pretty remarkable. And then often my patients, when you're programming, you'll have to figure out what works for them. Combo therapy in my practice has been the most successful. So running Contour with FAST or Contour with Illumina 3D to really get the best therapy. Sometimes patients like paresthesia, sometimes they want paresthesia free. And so this study in 2022 kind of shows us that 85% of our responder rates had 50% reduction in pain at 2 years. And also 85% of them prefer to have a combination therapy. So you have more options in the multiple independent currents and programming.
And you're seeing a lot of sustained relief. The 1 year study is great, but we don't have a lot of 2 year study data like this. So you know that this is going to be something that lasts for them.
Yeah.
That's great.
Yep. So we're going to just jump into kind of some of the stuff we're going to use now.
Okay.
Yeah, so we have our non-rechargeable battery that I just wanted to show you. Should I?
This tool right here.
Great. Okay.
There you go.
And another thing about this is the rechargeable battery as well. Boston Scientific's the only company that has 4 ports for their battery. So this is great because often you'll put in an SCS for lower extremity or upper, and then a patient may develop something in another extremity. Well, you have the ability then to go in and modify, add another lead, and not need another battery.
Oh,
So,
that's great.
yeah.
I'll show that here. You can make out the 4 ports.
Oh, yeah.
Perfect. Okay, great.
Yep. And then we talked about the 16 and 8 contact leads. We didn't have an 8 one today, but this is the 16 contact lead. Oops. You have to use the Intrada needle. This is the implantable 16. With the Intrada needle, it's pretty cool in that it has a couple components. So when you would take the stylet out to get your loss of resistance, and then before you put the lead in, you would take out the second stylet, and then you would pull this off as you pull the wire back.
That's really interesting.
Yeah.
Look at
So,
that.
and then it comes right out. So it's just really easy to use, and then you can, yeah. So, but for today, we're going to use the 16 contact trial lead. So, I guess we'll get started.
Okay, great.
Thanks. I'll use this as a point too. All right, so it's important to take a nice AP. So you want to square off the pedicles. Picture. Great. And I always start 2 spinous processes below and at the pedicles. So paramedian approach. Picture. And I make my cut down first before I do my implant. I don't cut around the needle.
Did you always do that?
No.
I feel like a lot of people start,
Yep.
you put the needle in, you're not sure, and then you do the
Picture.
cut down around it, and then you eventually
Exactly.
switch over and realize, it's just so much easier to cut down.
Yep, it is. And you can, depending on the back, we have a nice space here. But depending on your patient and how much, stenosis they have, it's really important steering the actual needle. So if we look at how it's cupped up, if you have a hard time getting into the epidural space, you can rotate it downwards, lift the hub, and that will help you to get into the space a little easier. Sometimes when you're walking off the lamina, you end up hitting, bone, and you try to redirect, but sometimes just flipping it and diving down, you get into that space a lot easier. All right, so that was a good loss. And then my 16 contact, do you see that?
This is right here.
Right.
There you go.
Also, once you get into this space and your patients with a little bigger body habitus, sometimes their breathing can make the needle come out. I was in a cadaver course teaching a fellow, and they were saying they have a hard time getting their lead through because their needle is always coming out. And so just advancing a little bit more when you're in that space will make sure that the needle stays into the space.
Absolutely.
Yep. And then sometimes, can you go live, please? Or a picture? Sometimes, like, you see how my lead there was going off to the right? You can turn the bevel of the needle and then picture. And that will kind of steer it back the other direction. You can go ahead and go live.
Yeah, well done.
Yeah, and so that's a trick that I use sometimes, because sometimes, can you bring the table?
Oh, sure.
Yeah. Sometimes when you're limited in your options in patients who have pretty significant stenosis, so you have to kind of work with what you get. So then you will go up. I usually go to T8, T7, usually 8, 9, and then we're going to anchor. So I anchor with this device that Boston Scientific has called the Fixate. Can we go? Perfect. And so this Fixate device is very nice because you can just deploy by pushing. I'll show you exactly how to do it. You take this, we call it the polar bear. So you see it kind of looks like a polar bear. Very cute. But we'll pull out the needle, and while you pull out the needle, you want to steady your lead so that you're not pulling it back. So I just do it in little small strokes, and then the minute I see my lead, I'm grabbing it with my fingers to make sure that everything just comes out smoothly.
You know, one thing that's unique about Boston Scientific leads is that they do come in that 16 contacts. Is that something you typically use in your trial patients? Are you using it regularly or sometimes?
Yeah, I usually always trial with 16 contacts because that gives me a lot more variability in the programming options.
Right.
And then if I can kind of narrow it down to what the target area is, I'll implant with 8. And if it's a wider area or the patient has a diagnosis that might require more coverage, then I would implant with the 16.
Yeah, absolutely agree.
Yeah.
I think it makes it great for trying to find that sweet spot. And if it happens to migrate a little bit, it's not as much of a big deal with the number of contacts. So it gives you a lot of range.
Yeah, absolutely. So I'm going to slide on this anchor. It helps, I like to put my anchors in some normal saline. It just helps them slide on easier. And then I'm going to actually extend my incision a little bit. It's always better to have to extend it than to make one that's too big.
I think one of the biggest pain points is anchoring when you do a perm, right?
Yep.
And so have you switched pretty much over to this using the Fixate device?
I have.
That's
Yep.
great.
Yep. Sometimes I'll also anchor if I feel like I want the anchor. I think it's very important when you're anchoring that the anchor is flat,
Yes.
and that sometimes the tip of it can come upwards depending on the patient's body habitus. So I think it's very important if you do get that tail that pops up to anchor that additionally.
Keep it in the same plane.
Yep, and then
100%.
also where you're tunneling, you don't want your lead to be kinked into your battery pocket.
Right.
So you want to make sure you're tunneling and it's a nice smooth transition, not any acute, angles or anything like that.
Now, what would you tell the viewers at home who only do trials, they send their perms out? Was that something you used to do and you switched, or did you always do your own perms? And how would you convince them to say, give it a try?
Yeah, I have always done my own perms, but I will say when I started my practice about 10 years ago, I reached out to a couple well-known neurosurgeons in the area, and I just said, hey, I introduced myself, I told them what my interests were, they didn't really have an interest in doing the paddle implants. Some of the other neurosurgeons did, but I wasn't in any territory wars. And I would encourage people to make sure they establish, should something happen and they need
extra help, backup.
Yep, or that they have it. And then after that, I think it's great to do your own implants, because often if you do send them out, they will get paddles, and then they get, bone. It's a little bit more of an invasive surgery. And with this, it's a pretty simple process once you get the flow down.
Right.
And the patients like to stay with you. They want you.
Yeah, they trust you. You've done the trial, and then they say, "Okay, could you do the perm, please?"
Yeah. So I would encourage you to go for it, and then find a mentor. Find someone in your community you trust, or someone from Whipham, or just a mentor of sorts that would help walk you through it. The morning before, the night before. Just be prepared with the steps, and just be methodical in your thinking, and you'll be successful.
Advice.
Yeah. So with this fixate, you pull the polar bear off, so it's kind of let it just hang loose there, and then can they see? So I'll hold it up here for the purposes. I don't think you guys can see, but you put it through one eyelet there, and so I can't even see really. It's usually easier and then you deploy once, you turn it clockwise a quarter turn, and then holding the anchor so you don't pull anything off, you lift up, straight up, and then you will stick it back down, and the other eyelet, deploy again, and then pull straight out. And so sometimes I've had this little clear piece come off if it's deep, but not often, and it's so much easier and quicker to anchor this way. Then you'll take this, I call it a pusher, but you push this knot down. So there's a knot here. Can you guys see the knot? Yeah, you can. Yep. And so there's a little slit in this, and it just shimmies this knot right down.
Instead of trying to have to push with your finger, you're pushing all those surgical knots.
Yep. And then I usually do a test where I pull it really hard to make sure that it's really anchored in well. And then there's a little blade on the tip of this that you can just cut it right there.
What a nice tool.
Yeah.
It's so much faster.
Yep.
I can tell you, anchoring is probably the most annoying part of the whole thing.
Yeah.
Yeah, you made it look really easy, and it was very smooth and very fast.
Yeah. Yep. And then we tunnel. So I think it's important also to mark your patients before you go into the OR. So have them sitting at the edge of the bed and mark, and make sure they don't have any shoulder pathology. See what side they sleep on. Also, a big question is, how do you get in and out of the bed? So if there's friction against the battery site, it's gonna be uncomfortable often, and so you want to put it on a slide that they maybe don't sleep on, or they don't shimmy out in and out of bed on, and that they don't have any shoulder problems with.
I think that's one thing that we do see a fair amount of variation among the physician community, and I think battery placement is a science but also an art.
Yes.
And how you approach that is so variable, but at the end of the day, you want to make sure you cover as many of those factors so that your patient is super happy. Because one of the things, you could have perfect coverage, but all they complain about is battery site pain. Right?
Yes.
So 100%.
Yeah. I've had several battery revisions that have come to me that, were not in places that were, comfortable for patients. So it's a big thing. So I always would mark that. And then the tunneler, I was going to show you guys. So I will make, I'll just go ahead and make a pocket incision. So I can show you how I tunnel. I usually have Sims and have someone retract this and start the plane, and then I'll dissect bluntly with my finger, trying to make sure I feel that it's about, that it's thick enough that it won't be painful, but it's not too thin, not too thin so the battery's right there under the skin.
Right, it's a delicate balance.
Yeah, it is, like you were saying. I always kind of curve upwards so that I'm not going down into any areas where I don't want to be with my tunneler. And then you apply some pressure. I also will inject lidocaine over this area. So when the patient wakes up, they're not really sore. So I'll tell them stick and burn. I do a lot of my implants under MAC. And so I inject a fair amount of lidocaine for the pocket with epi and for the tunneling. And so then you'll just tunnel there. This unscrews. Or should unscrew. Then just pull this out. You stick your lead through, and you don't move this until you start to see it come on the other side. And then once you see it, then you can pull all the way out, and you're tunneled. And then you want to make sure that there's no looping, that everything's just kind of nice and flush. And then you plug in your IPG.
That was super smooth.
Yeah.
Yeah, that's great. I think there are a lot of people who do a lot of trials and they want to get comfortable trying to dip their toes to do a perm. How do they get a hold of you guys if they want to learn this technique? What's the best way to do that?
Yeah, the best way to do it is just talk to your local rep. So someone that's going to be within the clinics, you probably have seen them around, and you can just get a hold of them and they can get you to a course like Dapper Lab, get you in contact with another physician that has some advice, and join that networking community.
Wonderful. Yeah, that was
And I
great.
would also say if you're starting to do implants, talk to your local rep about who in the community, if you're new there, might be a neurosurgeon that you should be in contact with if you do get in a situation you need help. That's a good resource too.
100%.
Yeah.
100%. Well, Dr. Nash, thank you very much. This was great. A lot of fun. Thank you.
Appreciate
You
it.
guys did
Thank you.
awesome. So that was Boston Scientific, guys.